We're partnering with NoCD to raise awareness about OCD. OCD is more than what you see on TV and in the movies. Imagine having unwanted thoughts about your relationship stuck in your head all day, no matter how hard you try to make them go away. That's relationship OCD. It comes with unrelenting, intrusive images, thoughts, and urges about your partner or loved one. Breaking the OCD cycle takes effective treatment. Go to nocd.com to get evidence-based treatment. Hi, and welcome to today's episode where I'm going to be chatting with Dr. Erin Reichlin, who is a psychiatrist. And this is a special episode because if you've been curious about medications or how medications work with OCD, what are the correct ones or the ones that just aren't a good fit, if you're struggling with severe forms of anxiety, worry, control, this was a really cool conversation because we got to talk about the different approaches and how to help someone who is dealing with a lot of intense emotions and how we can help you move forward in getting the help you need. Hi, I'm Erin, licensed clinical mental health counselor and OCD specialist. I'm also a wife, mom to 3, and small business owner, helping those who are spiraling from intrusive thoughts to come out of that valley with long-term recovery and self-awareness. Reheat your coffee and pop in your AirPods to learn how to boss up to OCD. Thank you, Dr. Reichlin, so much for being here. So happy to chat with you.
This is great. It's nice chatting with you too, Aaron.
Yes, and we connected over LinkedIn. I don't know how long we've been a connection on LinkedIn, but I mean, you're a psychiatrist in the field and you've got a lot of things that you're working on and doing. Do you care to share a little bit about your background and who you are?
Sure. Well, I'm based in Chicago. I've been a psychiatrist for over 20 years if you count my training.
Yes.
I trained at Northwestern where I finished my chief residency year in 2006 or so. And so I've been in private practice, at least part-time, for a long time. And recently I've been, in addition to having a private practice, a private psychiatric practice, which is both a medication management and psychotherapy practice.
Yes.
I'm also working on and running a small software company, a mental health tech company called PsychNow. And what we're doing with that is we're an AI application that kind of helps anyone in the mental health field, whether you're a counselor, social worker, psychologist, psychiatrist, small business, perform and do screening, intake, and ongoing care in a much smarter fashion. And so we're very
Awesome.
excited about what we're doing there. Yeah.
Yes, I'm sure. Well, and that's really neat how you've branched out to do other tech and AI tools because I mean that's kind of the way of the future and it's probably a huge help to all the practitioners.
Well, it's really, as a clinician, I think, as a clinician co founder, I think it's really important to have clinicians doing work in this field because it's important to have the clinician voices understood and heard and translated into products that matter to us, right, as clinicians. So that's what I'm really striving to bring to market and to bring to life for on behalf of everybody and all the patients and clients that we take care of.
Yes. So I'm super curious, how does the like consultation screening work with the PsychNow platform?
I'm the first user of this platform, and we'll have more users by the end of this year as our
Awesome.
product gets kind of more widespread. But what this does is it allows me to kind of gather the patient's story and present it back to me as the clinician in a way that's both clinically nuanced and really high quality and do it all faster. And even in my case, in a more cost efficient way for potential patients that I take care of. So it's allowed me to
Sure.
reach a whole lot more patients. And it's allowed me to be able to treat more patients too without losing a beat on quality.
Awesome. Well, that sounds great. And I'm sure that's especially helpful as a psychiatrist.
It's very helpful, I think, for anybody that needs to, screening and intake for in particular is a
Yes.
very cumbersome process.
Yes.
Um, Calling people, you know, checking to see if they're a good fit for your practice, or getting
Right.
them to the right person. Otherwise, it's time consuming, most all of which is not even reimbursable, right?
Totally.
Even if you're. So we've devised just a total front end to end, system that will
Mhm.
help anybody, kind of both evaluate with terrific nuance and
Yes.
graduate those individuals to a consultation to complete that process in
Wow.
really the most efficient way possible.
Well, that's excellent because, like, as a private practice owner, I've got my website and I try to market specifically to my ideal client. And even then, I'll get people, who squeak in and schedule a consult. And I'm like, oh, goodness, like, we're not a match. And so now we've just kind of wasted both our time. So, love that you have created this tool. And I think this is something very much needed for the mental health field. But anyway, let's get to like, why we're here today. I reached out with a question about, a lot of med management stuff because I'm running into at least one person who had some concerns about taking medication for OCD. So I really appreciate your insight and expertise. And so, and kind of getting started, Aaron, I'm
Mhm.
curious on your experience just in general whenever you have done medication for folks who are struggling with OCD.
Well, I certainly treat a lot of people with lots of different kinds of anxiety disorders, OCD being one of those. And what we know in terms of the evidence base is that certain kinds of therapies and certain kinds of medications actually have good evidence for managing OCD. And
Yes.
some have less, more counterintuitively, sort of like a problematic in kind of working with patients who have OCD long term. So we routinely use different kinds of antidepressants, even newer and older agents in combination to sometimes help control obsessions and compulsions for some individuals. And it,
Right.
of course, as you know, can be very disabling. But one of the hallmarks of treatment for OCD is exposure response kinds of therapies and other,
Absolutely.
which is so ERT, obviously very central for managing patients, clients with OCD. And medication management can be helpful alongside that.
Right.
But sometimes the medicines that one would think would be the most useful, like anxiety medications, anxiolytics, like benzodiazepines,
Yes.
Xanax, Klonopin, Ativan, while they are good for absolute emergencies, sometimes are counterintuitive and not necessarily good for patients with OCD, right?
Right. Right.
Um,
So many good points because you're highlighting how there you got to find that sweet spot with the medication. Not only are you finding the right, like, let's say Zoloft or Prozac or, something along those lines, but you're also taking note that the Xanax and the Klonopin are a not so good mixture for an OCD sufferer.
we do use medicines like this for people who have severe bouts of anxiety, usually when they're not with me or not during a session, but we don't generally like to use those long term for people with OCD.
Sure.
We like to get them into kinds of treatments that will actually help to eradicate or work through the symptoms, usually like with ERT, right?
Right. Yes. And thank you for bringing up the ERP emphasis because, in my work, I mean, that's the bread and butter. That's what I do day in, day out. Now, I am incorporating another theory, which is fairly new to Americans, like the inference based cognitive behavioral therapy. But anyhow, with
Mhm.
the ERP, it is so effective in helping patients. And I explain it to them like we're dipping our toes in the water and gradually getting used to a cold pool, say, for example. So, Aaron, just out of curiosity, like when you
Mhm.
have referred patients to ERP treatment, do they even tell you that they feel
Mhm.
scared or hesitant? They don't want to do it, they're nervous?
Oh yeah. I mean, and by the way, I apologize. I ERP, ERT, I kind of use them sort of in my head in the same kind of terminology, but ERP is like another abbreviation for the same thing. Exposure response therapy, exposure response
Yes.
prevention. The answer to your question is, I mean, this is a lot like if you have a knee surgery, right?
Mhm.
And you have your ACL repaired and you put it in a brace. The goal is not to walk around with the brace forever, right? The goal is to take the brace
True.
off and do the exercises in physical therapy that hurt like hell, right?
Yes.
But
Right?
but then it stops hurting, right? To some degree, right? So
Right.
it's not like you want to get rid of the brace all the time, but you certainly want to get rid of the brace in the moment or in the session in which you're going to work on strengthening the muscles that will make it hurt no more, right? Or no
Right.
longer. So
Yes.
I think that's a good way to understand how exposure response treatment works, right? And
Yes.
why you have to find the sweet spot with medications. The goal of medicines, in my view, is to be on as minimal of medication as possible to raise the floor and make the challenge, whatever it is, the session or the treatment at hand, just tolerable enough, right? So that you can do the work.
Absolutely. Yeah, I love that example about physical therapy because that's so true. I mean, people accept physical therapy when they have hip surgery, knee surgery, you name it. Like they know that's coming and that it's going to be painful, but they'll still do it because they know
That's right.
ultimately they're going to get better. I love this example. And that's so true for OCD treatment. Like it's going to be tough at first, but they can come out feeling stronger on the other side. So that's awesome. I love that you share. Yeah, I'm sure you share that example with your patients because it's so important that they get the right kind of treatment.
I have shared that example before. It's also hard because sometimes people have more than one anxiety disorder. They actually may have
Right.
more than one. And so while for OCD, benzodiazepines are really not the mainstay of treatment,
Yes.
sometimes having some benzodiazepines for somebody that has like a panic attack or panic disorder, it can be more useful. Fortunately, the same underlying methodologies and medication management work for both of these disorders, but it's good in terms of antidepressants, SRIs, and even other types of antidepressants. They tend to work for both of these disorders, but it's good to recognize and
Right.
understand that people can have more than one anxiety disorder, right, at the same time.
Right. Valid. We're partnering with NoCD to raise awareness about OCD. OCD is more than what you see on TV and in the movies. Imagine having unwanted thoughts about your relationship stuck in your head all day, no matter how hard you try to make them go away. That's relationship OCD. It comes with unrelenting, intrusive images, thoughts, and urges about your partner or loved one. If you think you may be struggling with relationship OCD, there's hope. NoCD offers effective, affordable, and convenient OCD therapy. NoCD therapists are trained in exposure response prevention therapy, the gold standard treatment for OCD. With NoCD, you can do virtual, live face-to-face video sessions with one of their licensed specialty trained therapists. It's affordable and they accept most major insurance plans. Breaking the relationship OCD cycle takes effective treatment. To get started with NoCD, go to nocd.com/savage. So, how do you explain to your patients, let's say they are concerned that they can't take their Xanax or they can't take their Klonopin, how do you explain to them that those medications are like counterproductive or they're not helpful?
Well, I'll kind of give them the example we just talked about with, physical therapy after a
Yes.
surgery,
Yes.
right? That, the some movement and rehabilitation is expected to hurt a little bit, right?
Mhm.
But kind of working through that in a safe manner and let them know that, I'm supporting them and watching and I'm going to make sure that the experience they have is going to not be intolerable. It'll be,
Right.
something that can be managed. That's kind of how I talk to patients.
Okay, great. So you're giving them the comfort and reassurance to an extent that they're not going to be doing anything that they can't tolerate. You're going to be there to monitor them.
Correct.
Yes.
Correct. And everything will be made sure to be safe and, within their grasp and within their ability to manage.
Right. So I'm super thankful to have you on the show today because I encountered a psychiatrist who told their patient that exposure response prevention would be quote unquote too intense and that they shouldn't do it. So I feel like there's a little bit of education that needs to go out to even, I guess, other psychiatrists out there. So, how would you respond to, say, a colleague who was a fellow psychiatrist and said, oh, ERP or ERT is too intense?
Well, I think that, people may have sort of varying capacities, both as clinicians and as clients, right? To sort of manage, and the art of kind of finding the appropriate level, right, of what's needed is an art that relies both on the
Yes.
clinician and the clinician's ability to sort of, assess a situation with a particular client or patient. So I'm of the belief that that can always be dialed, right, and adjusted. And so I think it's more, maybe that better is
Mm-hmm.
needed for both, both providers, clinicians, multidisciplinary clinicians and teams, and clients and patients.
Right.
That we all have to sort of remind each other how this works, and it really, I think, comes down to the clinician and making sure to, you know, help clients, patients, and collaborating providers, right, to
Yes.
understand one's orientation and background.
Right. So true. Because obviously, the exposure response prevention could be too intense if the provider was not attuned to their patient, if they were not paying attention to the signals, if they were not making the hierarchy. Basically, there'd be a lot of things going wrong, for that to happen and for it to feel too intense for the patient. Because,
That's right.
yeah, bottom line, I mean, any medical care provider is to do no harm.
That's right.
Yeah.
But it gets confusing, I think, sometimes when people understand that a procedure might be somewhat painful, but that doesn't mean that's not the right procedure, right?
And so true.
You know, that's a good thing to recall. I mean, other kinds of talking therapies can be painful too, right?
Yes.
It's not just ERP. That
Yes.
doesn't mean that talking therapy is the wrong thing to do either, right?
Yeah.
It's just good to remember that.
Yes. So, and now in kind of thinking about medications, a lot of times people, I'm sure they want a quick fix. They want to feel better right now. What is kind of the time frame in general when you're prescribing, we'll say SSRIs? What's the general time frame for someone to expect to start to feel better, to start to see results? What's that look like?
Well, it's hard. We have lots of data that says how and when and why someone might respond to a certain medication is certainly multifactorial.
Wow.
It's not one size fits all when it comes to not
Yes.
only medications for an individual, but it's so nuanced that the same individual could have the same medication prescribed by 10 different doctors, if this were theoretically
Mhm.
possible,
Mhm.
and have different responses to that very same medication. Because
What?
part of it is beyond just biologic, right? Part of it has to do with how and who that medication is being dispensed from, right? And
Wow.
so, what's said along with it, the trust, the therapeutic connection, the alliance matters a lot, right? And this
Wow.
is backed by research as well.
Yes. Well, I mean, it's
Um,
true in therapy as well.
right. So, in therapy, too, same principle. But it means that patients have to, have to work to feel like they can trust and be understood by the clinician that's working with them, whether they're a psychiatrist, a psychotherapist, or whatever their background actually
Mm.
doesn't even matter. So, with that said, it can often take, usually by the end of the second week or into the third week of taking a medication, to start noticing even the beginnings of a symptom. But I have had beginnings of symptom abatement
Mhm.
of one source or another. But I've certainly worked with, a lot of patients over many years where it takes longer, multiple medication trials and combinations that include things that are beyond just an antidepressant, right? And
Gotcha.
that's fairly common for me as a subspecialist to sort of work with people that need more than one. agent and more
Yes.
than one kind of 2 to 3 week period to kind of, get things adjusted properly. Right.
Right. Yeah. And so I kind of think about it like finding the right cocktail, but how do you phrase it whenever you're trying to find that sweet spot with the medications?
I think, we have some new tools that are at our disposal in the last several years where we can do some genetic testing to kind of get a little bit of a better pointer as to what
Yes.
kinds of medicines will or might work for certain individuals, or how we would at least expect those individuals to metabolize or respond to certain kinds of medicines. They don't tell us
Right.
exactly what will work, right?
Okay.
But they can guide us a bit. So in finding that cocktail, we have some ways that we can kind of make that a little bit more efficient.
That's
But in
awesome.
truth, I think the big predictor of finding the right cocktail is about establishing an empathic and trusting connection. And in today's day and age, it's
Mhm.
very hard to do this because it takes time to do so, right? And you have to really get the backstory and understand someone and then demonstrate that you understand and then know what to do about it, right? And so that process is really what I think has been damaged the most in our
Mm.
current environment,
Mhm.
in our field, and more broadly as time has gotten very short, the time that we can spend with people. So that's, by the way, partly what I've been working on trying to solve with the software at
Mhm.
PsychNow. I use it to kind of get hours and hours worth of material faster and assemble that in a way that helps people help helps them understand that I understand them, even after
Right.
just very short periods of time.
Yes, so that you can validate them and empathize with them and ultimately connect, because that
Exactly.
connection is honestly the key ingredient for their success.
If you make a cocktail that doesn't have a connection in it, you've made a really bad bar drink, right? Let's put it
Yeah,
that way.
yeah. So
Nobody will want it.
right. Well, and it's great that you're using these other tools like with the metabolism testing. And I've heard of some of those like GeneSight. Is there
Mhm.
a particular one you prefer, or do you just
I mean, that's the one that I'll usually use,
Mhm.
GeneSight. I've used that one for many years. There are others, though, that are that are also very good, but
Okay.
I just tend to use that one.
Yeah, and not a lot of patients know about the metabolic testing. They haven't even heard about it. And so it's really neat, at least, on this platform or even in a therapy session, just to let people know what resources are available.
It is cool. I mean, our tools are many and varied, but our best tools, I think, are tools that, have to do with what it takes to, help people feel like understood and that they can, trust that you understand what to do about it, right? So
Right.
this like empathy and the time it takes to build a connection is really the most essential and important part of any clinician's tool set, right? And
Mhm.
so that's really, I think, at the heart of it all. And this is some of the research that has been done around even medications and the importance of trust and connection in terms of their efficacy by
Yes.
many other researchers in our field.
Yes. So we've got the metabolic testing that kind of gives you a sense of direction on which medicines will metabolize or work with the patient's metabolism better. And then, two, they may see some results around week 2 or 3, but mostly, again, it kind of depends on the therapeutic connection that you have with the patient. So I'm curious, like, here's what I run into, honestly, time and time again. As with any anxiety or OCD condition, they want like not only guarantees and specific answers, but they also run into this common experience of being afraid to take the medicine. Even though they're in this space of like, I know it's helpful for me and I know it'll be good for me. I just don't want to. There's like a sense of fear or uncertainty coming up. Have you ever experienced that?
Oh, I mean, I have seen this clinically. Yes,
Okay.
I've seen this clinically. That the individuals usually who are want the greatest amount to change often have fear. It manifests in one way or another. And I actually think that's part of the condition of certain anxiety syndromes and
Mhm.
certain kinds of character constructs. And we see it a lot in patients with OCD. We see it a lot in
Yes.
patients with also perfectionistic tendencies and unwillingness. Yeah. So I do see this a lot. I think it's a great observation.
Right.
Yeah.
How do
So,
you help them
so
move forward?
again, I think it's really about almost beating them to the punch and wondering about. I mean, I will often say to people, I have a feeling that you're here because you know that you're hoping I can help you a bit more than what you've been experiencing. But at the same time, I wonder if you're afraid of things like medication. And so talking to them
Right.
about it, I think, is how you kind of begin to find the inroads to working on this, over time.
Yeah.
But that is part of the process, right? And part of what has to happen.
Right. And I have ran into this obsessive compulsive cycle so many times where they're afraid that if something good happens, then something bad is right around the corner. And so,
And yes, in many instances, you have to remember, contextualize this. Many of these people are afraid to leave their house if
yeah.
the oven burner was left on, even though it's
Yes.
off, right? It's the
Yes.
same idea. Like, even if you can reassure many times over that this is the case, that you're not going to get anywhere like that. Sometimes the work to do is actually ERP, right? With the notion of taking the medication, right? And
Yes.
and and trying to sort of break it simultaneously with the rest of the clinical approach, right?
Yes, because the other way that I have helped explain medication, like when someone's on the fence like that and they're like, oh, I'm afraid to take it. I don't know what's going to happen. And I don't know if it, ultimately if it will help me or if it will be bad side effects, whatever. I will tell them like that I view medicine as if you're in this situation like you're drowning in the ocean and there's like all these big waves coming at you, but the medicine helps is like your life raft. It helps you float. And that
Hmm.
way you can catch your breath and then the exposure response prevention is teaching you how to swim. So then you can come back to shore and be safe and well and happy and like, whew, I survived. I made it.
Yeah, you can think. I sometimes tell people that medicine helps you to have a fair shot and a level playing field, right? Where you're
Yes.
playing in like an unfair environment, right? Beforehand. The goal of the medicine is not to alleviate all the symptoms. In fact, it almost never does.
Mhm.
It's to raise the floor enough that you can take the step to do what will be hard, but not too hard, right? And
Right.
that's the goal.
Yeah. Now, just to maybe address any concern someone has, what are like common side effects?
Well, it depends on the medication
Sure.
that one is sort of thinking about or trying. But assuming that we're talking about SRIs, which are the most commonly prescribed,
Mhm.
most widely prescribed, because as you probably know, unfortunately, there's just not enough specialists to go around. And we have primary care doctors doing a lot of the prescribing,
Mhm.
and they're wonderful. I have many colleagues in the primary care space, but most of them are most comfortable with SRIs,
Mhm.
as a primary medication. So you'll see most people taking SRIs. So those medicines are medicines like Zoloft, oftentimes other ones, Paxil, Lexapro, Prozac. They all have similar side effects. They can make some people have, initially as they start, a little bit of stomach upset, a little bit of transient feelings of increased anxiety, even sometimes, that then all generally abates. That goes away.
Good to know.
The one side effect that I think people can have is some people can lose a couple pounds, some people can gain a couple pounds, but the particular side effect that does seem to affect some people more than if you were taking no medication is you may be more likely to experience sexual side effects.
Right. The low.
And fairly common. Either low libido or other sort of sexual issues. It can be a little bit different for men and for women, but that is a not permanent side effect that really only lasts once, as long as you're taking the medication, and goes away completely. If you do have the side effect, goes away completely once you would stop the medication. And it tends to be dose dependent. Yeah.
Okay. Okay. Well, we've covered a lot today, Dr. Reichlin. Are there any closing thoughts or words of wisdom or things that we haven't touched on?
I mean, I think this is a great, you know, kind of conversation about helping patients who I know suffer a lot from obsessive compulsive disorder. And I really appreciate the work you're doing to kind of, approach treating clients like this. It's very important work. It's very common. And I think the stats are about 2.5 to 4% of the population deals with OCD at
Mm-hmm.
some point.
Mm-hmm.
That's a lot of people, right? I mean,
Yes.
that's a lot of disease burden. But I think the main thing to remember is that in collaborative care with, like a prescribing clinician, a psychiatrist, or a nurse practitioner or primary care doctor, and a therapist have to really collaborate closely. And both of them, not just the therapist, both of them have to demonstrate empathic understanding of a client, of a patient, and, forge good connections for change to occur, and understanding where those roadblocks exist, and, where those things come up is really the art of good caring and good treatment. And
Awesome.
so, I'm delighted to talk to you about this today, and hopefully we can collaborate in the future on some clinical cases.
Sure. Yes. Well, very much appreciate your time again. And thank you so much for just kind of clearing the air on medication management for OCD and also acknowledging in your physical therapy example about how exposure and response prevention can be the treatment needed for the person to help be well, because that
Mhm.
may very well help someone else like take that leap or take that next step of courage to get their form of happiness, their form of contentment and peace that they haven't had in so long because OCD has robbed them of that. So I really appreciate again your time and your expertise and sharing all this with the listeners today.
It's my pleasure, and anybody that might be in Illinois listening with these questions or issues, I'm happy to consult with you, and and then also share my findings with whomever you might be working with and as a therapist, and look forward to helping whoever I can with this from a psychiatric perspective as well.
Yes.
So
Okay. And how can people connect with you if they want to find out more?
sure, you can find me most easily by going to my private practice website, which is freudly.com, freudly.com, and you can inquire there.
Okay.
And I've been, even though I'm out of network, using my new software that I've created, I've actually brought the price down considerably to be able to care for more patients, more clients, by doing expedited assessments that basically start immediately using our software. And we're very excited to have that end-to-end solution in place by the end of this year. But I can take people now as well too.
Right.
So it's very,
Okay. Thank you.
you're welcome.
What a great conversation it was with Dr. Reichlin. If you'd like to learn more, you can follow him on LinkedIn. And I'll also have this interview available on my website at valuedriventherapy.com. And I look forward to having you back here next week, where I'm going to be talking about the difference between actual sexual attraction versus unwanted intrusive thoughts that could be related to OCD. So that's going to be an exciting episode. So come back for that one. Thank you for listening to another episode of Bossing Up Overcoming OCD.
This information is intended to be helpful and not a substitute for professional counseling.
If you're struggling with any mental health challenges, I encourage you to seek help from a qualified therapist or healthcare professional. If you enjoyed today's episode, please take a moment to rate and review the show. Your feedback helps us reach more listeners, and don't forget to check out the affiliate links in the show notes for hand-picked recommendations that can brighten your day. Your support through these links helps keep the show running and provide valuable content. You're not alone in your journey. Stay strong, stay resilient, and keep bossing up. See you next time.